So this is our institution investigator-led trial called Cabo-Seq, where we are having 2 dedicated cohorts with different treatment strategies. So as you said, cohort 1 is really dose escalation to cabozantinib 80 milligrams daily, and cohort 2 is cabozantinib plus nivolumab in the combination for patients who are slowly progressing from prior cabozantinib. And the question really is, when people have some treatment resistance to cabozantinib, when their tumors are growing, how can we salvage some of their responses? And so the institutional knowledge and our expert experiences in the clinics was that some of our patients were having better treatment outcomes, some salvaging, some stable disease on higher doses of cabozantinib. So the 80 milligram dose is not an approved indication, and so we're trying to test that more formally in this particular study. The cabozantinib with nivolumab combination, also we've seen some disease stability in patients who have that salvage regimen, and so those are the people who we're thinking about to give the combination. Well, all of these are clinically meaningful endpoints, and so thinking about progression-free survival is helpful to tailor our sample size, and so that's an important endpoint from both disease standpoint as well as for larger trials for registrational purposes. But for this particular study, it's really to ensure that we had a controllable sample size and are able to enroll enough patients to have a meaningful difference. And we were really thinking about progression-free survival to improve upon what was historic progression-free survival for other patient populations in that very refractory setting. So I think making a difference for those patients will be meaningful. Now, for the other endpoints like objective response rates and duration of response, those are all ways that we think about trial design where we're also filling in the clinical pieces of other things that impact patient efficacy and assessment of how a drug works in that setting. Sure, they're mostly patients who we see in our clinics and the people who this trial would impact. And the one in particular that I think is meaningful for this trial is the 6 months of prior cabozantinib. So 6 months of prior cabozantinib with a slow progression allows us to make sure that Cabo, for example, at 60 milligrams was well tolerated before we would escalate them to 80 milligrams, and then also cabozantinib at 40 for the combination cohort also gives us a slower progression. Now, if these patients most likely have received immunotherapy treatments in the frontline setting before cabozantinib, then they also have a 6-month window to wash out, essentially, from prior immunotherapy combinations. And we think that T cells become more exhausted after a period of 6 to 9 months after their last checkpoint inhibitor. And so therefore, that allows us to also think about them as resensitized to checkpoint inhibitors. So for multiple reasons, that 6 months on prior cabozantinib was chosen as one of the inclusion criteria. I hope it's not too rigid in terms of the structured inclusion and exclusion criteria, and I think we'll have plenty of patients to consider for the study. So this is an investigator-led study by my early career faculty colleague and mentee, Dr. Janie Chin, and we're also opening with our friend and colleague, Dr. Tom Hudson. He just took a new role at Texas Tech, so we'll be opening our second site out in Lubbock at Texas Tech.